good afternoon. Thank you, sir. So I'll be presenting the PLATIPARP data, which was presented in ASCO 24. It was a phase 2 study of induction Docetaxel Carboplatin followed by maintenance Rucaparib in patients of metastatic CRPC who carry basically an HRR pathway deficiency. So it's expected that around 25% of patients with metastatic CRPC have inactivated HR genes. It's of course associated with sensitivity to DNA damaging agents such as platinum chemo and PARP inhibitors, as in ovarian and pancreatic. Since, they obviously have synergistic efficacy, but also we see resistance and cumulative dose toxicities with these. So this was a phase 2 study to see if chemotherapy with Docetaxel Carboplatin followed by maintenance PARP inhibitor till progression or intolerance would provide prolonged disease control. So patients harboring the HR gene mutation, they could have received a prior taxane or an androgen receptor pathway inhibitor, but not PARP inhibitors. These were enrolled. Treatment constituted of 4 cycles of Docetaxel and carboplatin chemo every 21 days, followed by Rucaparib, which was given continuously as maintenance until disease progression or unacceptable toxicity. So this was the eligibility criteria. Patients were identified by tumor NGS testing to have biallelic inactivations of BRCA1 2, ATM or other HR DNA repair gene mutations. They received induction chemo, maintenance Rucaparib. The primary objective was radiographic progression-free survival. Other exploratory endpoints were to see if there was improvement based on a PSA nadir, and they wanted to correlate tumor mutations in CTC and ctDNA. So apart from the biopsy done at the baseline, also circulating tumor cells and circulating tumor DNA was done at baseline prior to induction chemo, during chemo, and if at all on progression. The biopsy was optional. Of course, data of this has not been mentioned in the abstract. So the primary endpoint was clinical or radiographic PFS compared to the historical control of 9.1 months with PARP inhibitor alone. Of course, these patients did not receive prior platinum, and 20 patients were required to provide a 90% power to determine whether this treatment almost doubled the PFS, that is, gave a HR of 0.5. The secondary endpoints was to see if there was a 50% response rate in terms of PSA, the safety and overall survival, and also post-hoc subgroup analysis was done depending upon what mutations, whether there was a BRCA mutation, BRCA complex group mutation, and to see if patients who were refractory to chemotherapy, that is patients who did not have a PSA decline, whether they had any benefit with continuing Rucaparib. So 18 patients were enrolled between November 2018 and 21. Under enrollment occurred because there was lots of manufacturer support for Rucaparib prior to study completion. 11 out of 18 patients had received 2 or more prior androgen receptor pathway inhibitors. 50% had received prior Docetaxel. The HRR genes, the mutations included ATM gene, 7 of the 18 patients, BRCA1, 3 out of the 18, BRCA2, 8 of the 18, PALB1 in 1, FANCA gene mutation in 1, the CHD1 and SPOP1 mutation in 1 patient, with 3 tumors harboring 2 alterations. So at a median follow-up of 31 months, it was noticed that overall the PFS, that which was the primary endpoint, was only 8.1 months. So it was not statistically higher compared to the historical 9.1 months. So basically the primary endpoint was not met. The median overall survival in the entire population was 18 months. For patients who had a BRCA complex mutation, the PFS of course was close to, double, almost 18 months, and overall survival of 27 months. Other HR genes did not show an PFS and OS improvement. In fact, it was inferior compared to the intention to treat population. Again, the overall response rate in terms of the PSA 50% decline was seen in around 67% in all of these subgroups, but that probably did not translate to a PFS and OS, apart from those patients who had BRCA mutations. Again, those who were refractory to to chemotherapy, that is 6 patients who did not have any response, they did not have any benefit from continuing Rucaparib in terms of PFS or OS. And 33% experienced grade 3 or higher adverse events, including 1 patient having grade 4 thrombocytopenia. So this was the primary endpoint. Of course, this was compared with the historical data. So you can see for patients who had a BRCA complex mutation, there was some benefit in continuing Rucaparib post-induction chemo. Again, the overall survival also, the curve for patients who had a BRCA complex mutation seemed to be much better than for those with other alterations. Adverse events are probably as expected due to chemo, anemia, fatigue, leukopenia. One patient had grade 4 thrombocytopenia. So concluding, induction chemotherapy with platinum-based chemo followed by maintenance Rucaparib overall did not improve PFS with HR alterations compared to historical controls. For patients who had BRCA complex group, so similar to probably the PROFOUND and TRITON studies, those patients who have BRCA 1, 2, probably ATM are the ones who actually benefit. And for patients who are chemo refractory, in spite of carrying a HRR gene mutation, even if they receive subsequent PARP, it really doesn't help, which shows an overall overlapping mechanism of resistance when platinum is used prior to PARP inhibitors. So we will get data on HRR alterations, especially in the BRCA complex, from a phase 3 COBRA study, which is looking at optimal use of sequencing platinum and PARP inhibitors. So that is under recruitment still. Thank you.